Hi, I'm Dr. Lawrence Robbins, and this is part 2 of a continuing Clinical Pearls topics, general topics, and I do have an emphasis somewhat on neurology and psychiatry, and not just medicine, but general topics that are of great interest to young physicians and PAs and nurse practitioners. We will have a number of other lectures in this series and also other Clinical Pearls lectures. You can look at my YouTube, Lawrence Robbins, Robbins, and search for the Clinical Pearls section. First topic is Nsaids. They're really much safer in younger patients. Nsaids do contribute to an enormous amount of deaths every year, but they're very useful drugs. They're not addicting, they don't cause tiredness, and generally they're quasi-safe in younger people. But as we age, because of our kidneys and our stomach, there's more and more side effects. They contribute to a lot of GI bleeds, particularly in older folks. A lot of people take over-the-counter ibuprofen and naproxen, and they mix in aspirin and Excedrin, and pretty much we have all of a sudden a bleeding stomach. In younger patients, we usually have a month or 2 or 3 of symptoms. With older patients, we don't always get that, and they sometimes just present to the ER with a hemoglobin of 6 and might have an MI because of that. So they often contribute to disasters as we age. And also our kidneys, as we get older, we have less glomeruli working, and if you have a creatinine of 1.5 at age 65, which is borderline renal insufficiency, if we don't stop anything and stop the reason, by age 70, 72, it's going to be 2.1, and then age 78, 80, we're on dialysis, and that's disastrous. There are several COX-2 inhibitors available. Celecoxib was developed as a COX-2 inhibitor, easier on the stomach. Meloxicam wasn't developed that way, but it is a COX-2 inhibitor, and actually diclofenac is somewhat of a COX-2 inhibitor. So these have less irritation of the GI tract. We have previously several other COX-2 inhibitors that are off the market, Vioxx and Bextra. Vioxx particularly was a very good pain medicine, but unfortunately it was taken off the market somewhat prematurely probably. That's a long, old, terrible story. Aspirin is very controversial. The dose, who should be on it. It can prevent MI and stroke and a few cancers. Most Nsaids, if you're on them for a couple of years, will prevent several cancers or make it less likely. But primary prevention is the problem. With aspirin, the number needed to treat is pretty high, and particularly after age 65 and 70, most people are going off aspirin. So if it's primary prevention, we're less likely to use it, but it's really a case-by-case basis. Some people, even after age 70, should be on aspirin probably. And the dose is also controversial. After 140 pounds, a low-dose 81 milligram low-dose aspirin is probably not sufficient for many people. We have aspirin resistance where it's not really affecting the platelets. Early on, a cardiologist checked 4,000 consecutive patients in his office and really thought that many were aspirin resistant, so we're not doing that much. So maybe we should be checking for aspirin resistance. But above 140 pounds, at least half of a regular 325 aspirin or 2 low-dose baby aspirins. So it's really a case-by-case basis. I do think it's worthwhile still in some high-risk individuals. And you have to look out for drug interactions. SSRIs are actually mild blood thinners, which may be partly why we see less recurrent MIs. Maybe it's also an effect on anxiety if people are on SSRIs, and also probably lower mortality. Several studies indicated that on SSRIs. That may be partly due to blood thinning effects. But there is an interaction then with aspirin. So as we get older into our 60s, 70s, 80s, people on SSRIs have slightly increased risk for bleeding and also on aspirin. Alcoholics particularly, alcoholics always are increased risk for subdural because those bridging veins between the pia and the dural sinuses become stretched, and also the platelets aren't working well as well, and alcoholics fall and bump their head more often. After age 70, we need to have more discussions about prescribing medicines in older patients, 70, 75, and the very old, 85, 95, 100. It really is different. But at all of these ages, we want to minimize medicine. We need to look at every medicine they're on. We won't stop other physicians' medicines, but have the patient call, or we can call, or the physician can call us to decrease some of these medicines. If we look at risk-benefit and the number needed to treat, really a lot of these medicines we can discontinue probably in older patients. A lot of patients are only seeing specialists, and there's really no one doctor overseeing everything. And we really need to assess all of these medicines. Osteoporosis is often overlooked and undertreated. I do see a lot of people who may or may not have had a bone scan, say they had a bone scan and they say, oh, I was told I have osteopenia, I have early osteoporosis, but I read about the medicine on the internet and they're dangerous, and so I'm going to ignore it. Or sometimes the healthcare provider is ignoring it too and saying, come back, take vitamin D and calcium, and we'll redo a test in a year. We really need to get aggressive, and I have an honest discussion with these patients that, yes, 1 out of 800 patients is going to have a side effect, GI, esophagus, etc., with the biophosphonates, for instance, but it's usually people who had a really bad dentition and jaw and teeth to begin with, who have necrosis there. It's rare, but the reality of osteoporosis, I say you are going to step wrong and break your ankle. You're going to cough and break a rib or two. You're going to shrink in height. It's almost invariable once you progress into osteoporosis. And even though the drugs aren't guaranteed to decrease fractures, we have probably better results on our bone scans from biophosphonates and even the osteoporosis drugs like Prolia than we actually have in reality decreased fractures. I don't think we can sit by and just ignore them and do nothing. Steroids are very useful. We use them in low doses. I think that the steroid packs are overused. They were really developed for asthma and allergies, allergic reactions, not regular allergies. So they're easy to prescribe. You write Medrol dose pack, prednisone, dexamethasone, and they end up with too much cortisone. You don't need that much. Often we'll use 5 or 10 or 20 of prednisone or the equivalent with dexamethasone. About 4 milligrams of dexamethasone is equal to about 22 or so of prednisone. And with headaches, we'll stop them once the headache is better. You don't really have to taper off cortisone unless people have been on it for 10, 12 days every day. And even from short courses of high dose, you can have severe anxiety. You can have psychiatric hospitalizations from psychosis. You can have GI bleeds. And if you're really unlucky, but this happens, you can have a necrosis, femoral head necrosis, knee, shoulder, usually femoral head. It's more likely in smokers, older male patients who are smokers. So our typical cluster headache patients have had more likelihood of severe reaction with bones and necrosis to cortisone. We write everything down in very simple terms for the patient. So if I say take 1 aspirin a day, if you don't write that down, it's unlikely they're going to remember and they're going to do it. So with televisits, we sometimes scan and email the instructions. It's really important. We do have different rates of compliance with different illnesses. Epilepsy, for instance, has lower compliant rates with medicine than pain patients. If you write 1/2 or 1 every 6 hours, say they're on a pain medicine, and you want to be, they're on a half a pill or a stimulant like Adderall, and you want them to be able to get more because they can only get, say, with Schedule 2 drugs, 1 month's worth, and you write 1/2 or 1, but they're on a half. Most of the time, the patients are going to actually increase the dose and take 1, and that's a problem. If you want them on a half every 6 hours, 1.5 or 2 pills a day, they'll start taking 1 a day, 1 every 6 hours, and all of a sudden they're on 3 or 4 a day. Dosing once a day is ideal. The drugs rarely last 24 hours, but meds dosed 3 or 4 times daily have very poor compliance. And be very careful with controlled substances. You really have to limit the amount, limit refills. It's crucial. We do PMPs on every patient, every visit. Patients often forget what you said. They don't understand. There's been studies where physicians were the patient, and they asked them afterwards what happened in the visit. They interviewed them a day later, and even physicians only remember a certain percentage, definitely less than 50% of what went on, and they didn't integrate at all. There's a lot going on in a provider-patient visit, emotionally, information-wise, so you have to keep it really simple in lay people's words. If we say you have a cervical radiculopathy, they often may not understand that. If we say there's a nerve being pressed and pinched, they're more likely to say it, to understand it, and that helps. You know, beware of the data mining studies, for instance, out of Kaiser in California. These are very valuable. They may assess 1 million, 1.5 million charts, but these are associations. They don't mean cause and effect. For instance, several years ago, it was said that benzodiazepines and the Z drugs, zolpidem, zaleplon, the trade names Ambien, Lunesta, and Sonata, are associated with dementia. And that hit the lay press, and everybody worried, oh my God. But it doesn't mean cause and effect. And indeed, you have to wait for further corroborative studies. And this turned out to be an association and probably not cause and effect. It's much more likely the insomnia, which is definitely a cause of dementia, is the culprit and not so much the drugs. Another data mining study, on the other hand, linked anticholinergics with dementia. And unfortunately, further studies did reveal that there was a cause and effect. We've had similar studies, for instance, with PPIs, such as Prilosec and similar drugs. And unfortunately, those are holding up as causing long-term side effects. We're not sure which ones. You know, it's been banter about renal insufficiency with PPIs, osteoporosis, which is holding up, dementia, and several others. With doses, you're always going to do better long-term compliance-wise going low and slow in general. There are some exceptions where you start higher. But for instance, amitriptyline, commonly used for headaches and other things. In the world, amitriptyline is the most commonly used headache preventive by far. And if you start on half of a low dose, 10 milligrams, and wind your way up slowly, you're going to have a heck of a lot more people stay on it than starting with 25 milligrams. Some patients are very desperate. They come in and they have severe pain, severe headaches, and they say, I just need to get rid, I can't wait 2 months, so you might start with higher doses. And some drugs have very few side effects, and lower doses don't work that well. A couple of the newer headache drugs, such as Qulipta, which is atogepant, fall into that category. Early positive results are not always the best. SSRIs, if they work in a day or two, that's usually the placebo effect. They really need to work through a different mechanism with genes and receptors, etc., and the early placebo response with SSRIs actually turned out to be less of a response later on. So some drugs we need to wait 4 to 6 weeks before giving up on them. Actually, with SSRIs over time, over 2 or 3 months, they work better. SSRIs are probably better for anxiety than for depression. And the problem with migraine preventives, many people quit them early. We don't get to adequate doses for enough time, usually due to side effects. When we look at ANAs, we reflexively order a SED rate or a CRP and an ANA. SED rate is more of a lab test looking at the red cells falling down. CRP is more of a physiologic liver test, but they look at similar inflammation. CRP is quicker. And with the ANA, we get back a lot of positive ANAs. What does that really mean? But 4 out of 5 patients are not going to have a rheumatologic diagnosis. So they really need symptoms of lupus or Sjogren's or mixed, etc., RA. So we ignore the lab's normal. Each lab has their normals. You have to know what the regular normals are for creatinine, for liver tests. Some labs will list liver irritation at if the SGOT or PT are above 40 or even 35. Some will list the creatinine is all over the place. You have to know the normals. An ANA of 1 to 40 I do not consider positive. And we don't follow the ANA. It's not like, oh, it's 1 to 160 or 1 to 80, and the next time it's 1 to 320, it's getting worse. That doesn't mean that any disease is there or that it's getting worse. So rheumatologists are not all that keen on referral just for a positive ANA without any symptoms. But the immune system really contributes to many, many illnesses. In 1987, I was convinced that the immune system was a key in headache, and we did a number of immune-based studies at NK cells and helper suppressor cells. I really think it is. It's not written in stone that the immune system is a key player in migraine, but also depression. There seems to be inflammation. And other central sensitization syndromes, there's a number of them. Fibromyalgia probably also involves the immune system. Small fiber neuropathy with fibromyalgia, and some small fiber neuropathies are autoimmune. So when we look at a large number of patients with depression, the ones on anti-inflammatories or aspirin did have a slightly less incidence of depression, but the effect size in any one person is fairly small. Remember that people take each other's meds. Mom often will say, well, my daughter Caitlin has ADHD, because ADHD is very, very genetic, and I think I have it as well. And I don't actually even ask Mom, have you taken Caitlin's Adderall? I say, what dose did you try? What dose works for you? Because most people have. But spouses take each other's meds. Parents take kids' meds. Kids take parents' meds. People take somebody who's dying of cancer's meds. People take their dog's meds. Our dog's meds, 80% of them are very similar or the same as humans. Gabapentin, tramadol. So if a young person has an addiction problem, they often steal parents' pills, even if parents keep them locked up. There's sites on the internet, and I've had 3 or 4 situations where the young person learned on the internet how to steal into the safe. Meds often do stay good for years. So if people find your typical med 2 or 3 years later, or from 2 or 3 years ago, it usually is still going to work, or almost always. The tablets may stay good for decades or longer. The Pentagon's looked at this, and recently there was a pharmacist in California found a bunch of medicines in the back of the pharmacy. They tested them, and they were reasonably potent from the 1960s. So if they're in high heat or humidity, meds are going to degenerate faster. Aspirin may actually degenerate more than some other meds. Liquids don't seem to do as well over time. But we don't want people to keep medicine around for that long either. People look in the medicine cabinet like spouses do and say, oh my gosh, look at all these medicines that you're on, and people get mixed up and take their old meds. We do want to generally discard them. But they may very still work. We don't have to get rid of things because it's 6 months past expiration necessarily. In other countries versus the US, they may have a longer expiration on the same medicine. Compliance is generally poor, as I mentioned a little bit earlier. Different illnesses have different rates of compliance. With epilepsy, people don't refill their meds, they miss doses, they take them the wrong way, one way or another. So we really pay attention to half-lives for a lot of reasons. And the long half-life medicine, say in epilepsy, a cheap one, phenobarbital from 1918. It was really the first epilepsy medicine, if you don't include bromides from the 1800s. And phenobarbital has a 90-96 hour half-life, just like fluoxetine, or aripiprazole has a very long one. So phenobarbital, if somebody has money issues, if they have generalized epilepsy, and they run out of their medicines often, or they don't take them, phenobarbital will keep working. It's not a terrible choice. It's used around the world with phenytoin very, very extensively. The most common ones around the world are phenytoin, which is Dilantin. We don't really trust the generic, and phenobarbital. With schizophrenia or schizoaffective, there's notoriously low rates of compliance. So you can improve compliance in a number of ways. Writing all instructions down help. Going over the medicines constantly with patients. Having them have that little plastic daily or weekly medicine boxes that they can fill up. But older patients often are very mixed up and they don't take their medicines right. It really helps to have somebody else watching over things. Once daily dosing is ideal. And with older patients, as I mentioned, we really have to try to minimize meds. Long-acting drugs are not all the same. There's various technologies. Some work better, some don't work. There's a lot of names for them: LA, SR, XL, XR, etc. Some are solid tabs with layers, such as OxyContin, that peel off as the medicine goes down through the GI tract. Most are really absorbed in the small bowel, the jejunum. Some of the long-acting are multiple little beads, which I think generally works better than the solid tablet that peels off. And they can formulate these beads in an interesting way, where some are released 50%, say, right away, immediate release, and some are slow release. So for an example, Ritalin LA has 50% immediate and then 50% over 4 to 6 hours. Patients like this, and it's now generic. It's been a good product. ADHD patients generally want things front-loaded like this. Ritalin SR, on the other hand, has been disappointing over the years. Xanax XR has also not been a very good product. But there's a long-acting morphine, just as an example, Cadian, which has really been a good product. It's now generic. Cadian probably works well for 16, 18 hours, which is pretty long. So if you dose a low dose twice a day, you get a very, very steady level. The long-acting drugs generally are smoother. Sometimes there's less adverse effects. People like venlafaxine ER versus short-acting venlafaxine, which we don't usually use. Topiramate is a good example. It has a long half-life, but the blood levels of the short-acting topiramate are not very good. It goes up and down. It really makes more sense to have a long-acting form of, say, gabapentin with a short half-life. But the long-acting topiramate, one of them, Trokendi, is a pretty good product, and it's difficult sometimes to get it paid for, as with many of the branded ones. But people prefer Trokendi, about 70% to 30% preferring the immediate release. There is a generic long-acting topiramate, topiramate ER. Grelise is a very good long-acting gabapentin, but it has limited indications such as post-herpetic neuralgia, and payment is an issue. The long-acting meds, as I alluded to, don't last quite as long as we'd like. Many say they last 12 hours. They only last 5 to 7. So if we dose them twice a day, we might get a better smooth level. OxyContin was always a big problem. And initially they did some studies and they flattened out the curve logarithmically. And the bottom line is they claimed it worked 12 hours and it hasn't. There's been a lot of talk in documentaries. I did one and I've contributed to articles and I testified in these cases. The problem is almost everybody who takes OxyContin says it only lasts 5, 6, 7, 8 hours. So then you have the end of the dose withdrawal phenomenon. People start taking it, they're going through withdrawal, and they end up on 3 or 4 a day instead of 2 a day. Then their insurance won't pay, then they have to go to the street, and it looks like they're overusing a pseudo-addiction. So that's a problem. Adderall XR is longer acting than plain Adderall, but some people like the plain Adderall better. These are generic now, mixed amphetamine salts. So with Schedule 2s, such as these, the stimulants, you can only usually write 1 month at a time. Sometimes you can write more. Vyvanse is actually a nice longer acting form of amphetamine. It's a prodrug, so it has to get metabolized through 2D6, but a lot of the prodrugs are 2D6, such as the opioids. But if you're a hypometabolizer genetically, or you're on a medicine that's an inhibitor of 2D6, you're not going to metabolize it to its active form, and it will stay at the inactive form and build up. That's a problem. The opioids, codeine, for instance, is not active. It has to go to morphine. Hydrocodone is metabolized to hydromorphone. Oxycodone is actually metabolized to oxymorphone. Tramadol, which is the most commonly used pain medicine in the country, it's an opioid. It's Schedule 3, it's not Schedule 2. It has a major M1 metabolite. So we look at the half-life of metabolites as well. There's a newer antipsychotic, cariprazine, Vraylar, which has a metabolite that lasts at least a week. It's a long, long acting one. Orexins are interesting. Orexins are an incredible system that are really under the radar. There's only 15 to 20,000 orexin neurons out of about 100 billion in your brain. We have about 10,000 trillion synapses and connections coming in and out of the synapse, probably 50, 100 quintillion. So, but as an aside, the very high-end computers were able to do this level of calculations that much by 2008, 2009. So these little bit of orexins, drop in the bucket, really are very important for your energy level, happiness, lipid metabolism, feeding. It's amazing what these do. And they project all over the cortex. They were only discovered 1998. They were initially called hypocretins. And several drugs do work on for insomnia on orexins. They block orexins, the suruvexin type drugs, Balsamra, Dayvigo, a newer one. They're not addicting. They can leave you feeling sort of crummy the next day. They don't get people as tired. They don't knock people out like benzos or the Z drugs. Some current drugs may actually influence orexins, maybe modafinil, which is very helpful for tiredness, and it doesn't have the increased blood pressure and pulse of the stimulants. So it's occurred to me with orexins that some people with what I call unipolar bipolar, they're always up a little bit, they don't need more than 4 or 5 hours sleep, they have pretty darn good brain chemistry, they feel great, they can accomplish a lot. There's not many people like this. I wish I had that brain chemistry. But many of these people also don't feel euphoric or up. They're a little bit anxious, dysphoric. It's not such a great feeling, more of a mixed state. But there are those people around. I really think healthcare workers, and we need a federal laws, should tolerate no abuse from patients. We've seen an increase. And we've always had a zero abuse policy in our office. We dismiss patients. But in training, or you work for big corporate medicine, it's a problem. I think corporate medicine really, really has to have this and should dismiss more patients than they do. Patients in 1980 or 1990 didn't have the power they have now. Social media, lawsuits, etc. And physical violence and emotional violence against healthcare workers is a big problem. You know, in medicine, very little is new. Faulkner did say the past is never dead. It's not even the past. So there's many examples. In 1900, we were sneaking in aspirin from Canada. It was a lot cheaper in Canada, but then that stopped. There were a lot of fakes coming in, like talcum powder, because that was cheap. Aspirin was expensive. And of course, after World War I, we nationalized aspirin because it was made by the Bayer Company, which was German. There was a quote, the typical opioid addicts in their 30s or 40s, women just as much as men, and that was actually from the 1850s. So those old British Medical Journal and JAMA articles from the 1800s are really fascinating. There was another quote that the typical drug representative is a good-looking young man dressed well, bringing their samples and wares to the office, and that was 1896. So sometimes nothing is really all that new. Now, ideas usually go in cycles in medicine. There's a lot of examples. Hypothyroid. When I trained in the 80s, the mantra was don't treat borderline thyroid. You're homeostatically, it'll knock your own thyroid down. It's a pain to take thyroid. You have to take it on an empty stomach. People are stuck on it. And then that changed. In the 90s and 2000s, the mantra became everybody has hypothyroid, even if they don't have high numbers, even if their TSH is 2.0, they might have dry skin, they might have edema, they might have tiredness, they might have weight gain, and a lot of people went on thyroid. Interestingly enough, there was a study several years ago that was randomized where some people went on thyroid, some people didn't for borderline. 2 years later, the people, and this is no surprise, on thyroid actually had slightly more symptoms. So the mantra changed, and I think that studies like that change things. You know, a major study like that was on knee surgery. We used to have a lot of cleaning out of the knee of arthritis and meniscus and cartilage, and a randomized study several years ago after age 50, several years later, the people who did not have knee surgery were actually doing somewhat better. So we need these studies. Similarly, the case with estrogen. In the 80s, menopause was actually almost treated as an illness. Everybody was encouraged to go on estrogen, and it does help skin and bones and brain. We're still debating whether estrogen helps prevent dementia. It's iffy, but it helps a lot of things. And hot flashes also. And then in the 1990s and 2000s, really the tide turned. Don't use estrogen, the risk of breast cancer. But really, the doses are much lower. A lot of women are on bioidenticals. And we're back in the middle. The pendulum swung back where each woman should be assessed for risk-benefit. A lot of women do better on estrogen, but certainly not everybody needs it. And we're using lower doses. Another good example is opioids. The mantra was, not that long ago, pain is the fifth vital sign. There's a huge amount of chronic pain. Don't undertreat pain. And then the opioid crisis came about, and it became, don't use opioids. Pain patients are bad, the medicines are bad, and pain doctors are bad. And there was a lot of stigma against pain physicians. People would land in the ER or in a general office, And they said, who's giving you this and why are they giving you that? But now we realize really that the vast majority of opioid overdoses involve fentanyl, which people get over the counter, and to a lesser extent heroin. The prescription pills have really taken a back seat. They're a factor in 5-10% at most. So the pendulum has swung back again as usual.